Good morning and welcome to Medicine Grand Rounds. It's really a pleasure for me to introduce our speaker today. Dr. Eckel is part of the chair's Distinguished Speaker Series, or the Dream Speakers, and our chief resident in primary care, Vidya Abraham, identified him. And he's been, as you'll hear, he's an alum, and also he was been able to spend time with our endocrine group yesterday, and we'll be visiting with old friends and colleagues today. So we've really enjoyed Dr. Eckel being here so far. He is took his undergraduate degree at the University of Cincinnati and his MD at the University of Cincinnati College of Medicine, where he was an AOA graduate. We were very fortunate here to recruit him to internship and residency at the University of Wisconsin in the Department of Medicine. He then went off to the West Coast, where he undertook fellowship in metabolism and endocrinology at the other UW in Seattle. He took his first faculty job as an assistant professor at the University of Colorado Health Sciences Center in Denver, and rose through the ranks to associate professor. He was vice chair for research affairs, and currently he is a professor of medicine, a professor of physiology and biophysics. He's the Charles A. Boatler Endowed Chair in Atherosclerosis in the Department of Medicine, and an adjunct professor of pharmacology. You got a minute here, Bob. He's published broadly, and is someone with 1 foot in endocrinology and 1 foot in cardiology, especially preventive cardiology. I made note of 291 publications, including high-profile journals, including Lancet, New England Journal, and the Nature journals. He also has authored 34 letters and editorials and 29 chapters. He's been very well funded by the NIH, NIDDK, and various different organizations. And he's an avid educator, even having lectured to one of our own chief residents who remembers his lectures fondly as a medical student back in Colorado. I counted 40 pre- and postdoctoral trainees who have worked with him. He's been a luminary nationally and a great volunteer. You're doing the same thing I do. You get closer when you get.
Yeah,
you're running out of time.
You off
you're not. It's not going to work, Bob. So he has served as president of the North American Association for the Study of Obesity, the Association for Patient-Oriented Research, and is past president of the American Heart Association. He's served on 11 editorial boards and been a participant at the major meetings crossing in endocrinology and cardiology. Among his honors, he's an elected member of ASCI and the American Association of Physicians. He's received multiple teaching awards. He's received the Gold Heart Award from the American Heart Association and the Distinguished Alumni Award from the University of Cincinnati College of Medicine. Up until now, he has never been a dream speaker, however. With that, it's really my pleasure to introduce Dr. Eckel as he provides grand rounds for us entitled Obesity and Diabetes, Science Linking Mechanisms with Therapeutics. Please join me in welcoming Dr. Eckel.
Oh, wow. Now after that, this dream speaker is going to be a nightmare, isn't it? Well, that's very kind, Rick. Thank you so much. It's good to be back. I remember this auditorium. I'm not sure the seats were the same. In fact, I kind of think they were plywood. And the idea there, if you came to a talk in this auditorium, you couldn't fall asleep because the chairs were so uncomfortable. But anyway, the building is the same and many fond memories. And I had no idea when I came here as a resident in internal medicine in the mid-70s that ultimately I would have the privilege of having a career that's been just outlined for you. Too much detail for sure. So at this point in time, we're going to take a look at the topic for today, and I gave that page a number of topics, and this is what was chosen, and I think it's one that fits kind of my research history and also my role in several major organizations. So I'm going to talk about obesity and diabetes, the science linking mechanisms with therapeutics, and I think, as we think about obesity, in the 1970s, I think there were a few people doing the science of body weight regulation, but there was no clue that the epidemic of obesity was going to be what it is today. And obesity, just as in someone who's sedentary and eating too much, there's really a lot of science behind weight regulation that exists at the level of excess body fat. And I hope to review that a little bit with you here today. So duality of interests have no role. This is a general slide. Unicure is a gene therapy company that we're working with, ultimately who's now removed their product from Europe. This is the first gene therapy that's ever been approved, and this is LPL gene therapy for people with LPL deficiency. Has no relevance at all to this talk. And Novo Nordisk and Regeneron basically relate to work in lipid metabolism, which I'm not going to talk about today, or in diabetes, but Novo Nordisk has no relationship here. All right, so let's move forward. So my objectives today is to understand the mechanism for the transition from obesity to glucose intolerance and then to type 2 diabetes, examine the rationale and approach to the prevention of type 2 diabetes in obese patients, and then to see how obesity in patients with type 2 influences therapeutic options. So that's the goals of today's talk. And let's look at those pathogenic factors that relate to obesity and type 2 diabetes. My bad. These remote systems are often a little bit thumb clumsy. So anyway, we're thinking about genes. I'm going to talk about that a bit more detail in terms of the monogenic and polygenic nature of obesity genetics. The environment, food availability, diet composition, physical inactivity really, and drugs all relate to the obesity epidemic. The pathway adjustment relates to development and actually even prenatal and intrauterine factors and postnatal factors. And then we're in the age of epigenetics, where modification of gene sequences really isn't what we're talking about. We're talking about gene structure and function as modified by factors in the environment that have yet to be adequately evaluated. And then there's the whole psychology, the behavior that relates to obesity development and its maintenance, the whole issue of depression and anxiety that relates to this, and then the cultural differences in acceptance of excess body fat. And that really differs in various ethnic and racial groups that we have to take into serious consideration. Now, if we look at the lifetime risk, here's the genetic risk. So if you've got a parent with type 2 diabetes, the chances are about 40% to get type 2 diabetes when you become an adult, and ultimately obesity is a major risk factor for type 2 diabetes. But if both parents have type 2, then there's about a 70% chance of getting type 2 diabetes. Now, despite the genetics, and we take histories in the clinic that relate to parents and their history of type 2 diabetes, the genetics that are based on family studies really don't represent the gene burden. So here we're looking at type 2 diabetes incidence on the y-axis and BMIs and fasting plasma glucose. And by the way, if your BMI is up, you've got a family history, and now your fasting glucose is above 100 milligrams per deciliter, that risk really goes up substantially. So the factors in the clinic that relate to real-time medicine is family history, BMI, and a fasting glucose that's in the impaired glucose tolerance range. Those are the three things. And look at the likelihood of developing type 2 diabetes if you have all three things going for you. We're talking about a third or 35% of people will develop type 2 diabetes. Now let's turn a bit to what we know about the genetics of obesity and how that relates to type 2 diabetes. Well, there are monogenic disorders, and probably the most fantastic among them is leptin deficiency. I mean, this comes from very sophisticated experiments carried out at the Jackson Laboratory, where in fact mice with mutations of what we now know to be the leptin receptor or leptin relate to obesity in animals. And with crossbreeding and cross-circulations, it was found that one of these defects was a receptor alteration, and the other was a protein deficiently mouse that ultimately developed this obesity phenotype. But now with the discovery of the leptin gene and the identification of patients with frameshift mutations of leptin, ultimately we know that there is a therapeutic advantage. Now this is a rare disorder, so this is something you can screen for in that child who's 3 years old and who weighs 100 pounds. And the benefit of screening for this is the therapeutics. And now we have a protein, leptin, that can be replaced. And you can see the benefit of giving that protein. This is the Oxford group, but this has been repeated now extensively at the NIH by Phil Gordon and his group. So this is a rare genetic mutation. So here's the pathway. Leptin's produced by adipose tissue, binds to the leptin receptor, which is actually in many tissues, but the primary site is in the hypothalamus, and we have a lot of downstream signaling that relate ultimately through the POMC gene product to MSH to the MC4 receptor. And by the way, mutations all along this pathway have now been identified that relate to monogenic forms of obesity. And basically, when excess body fat is severe in childhood, this is only 2 to 5% of obesity. Now we're talking about a very qualified application of these genetic disorders. And of course, the melanocortin-4 receptor normally operates to decrease food intake and increase energy expenditure. So when you have mutations anywhere along this pathway, we have alterations in energy balance that relate to the endpoint. Now, if we look at gene variants associated with BMI and waist-hip ratio, and those for waist circumference are in white, and then gray are GWAS for fat distribution, and ultimately we have one that also relates to type 2 diabetes. You see the multiple genes up to the year 2010 that have been identified. Well, let's look at the next slide. Here's the current gene map. Monogenic or allogenic disorders, polygenic or BMI related, overweight or obesity related, and those relate to fat distribution. I mean, we're looking at hundreds and hundreds of genes that have been confirmed in more than one population that now relate to obesity. And ultimately, when we're looking at abnormal glucose homeostasis, these are, again, rare monogenic defects that relate to insulin secretory defects or disorders that relate to insulin resistance. And again, typically rare disorders that relate either to obesity and or type 2 diabetes to follow. But ultimately, as we turn now to gene variants in 2010 that related to type 2 diabetes, FTO is the gene that relates to obesity and type 2 diabetes that ultimately relates to increases in food intake. But notice the predominance of the other genes relate to insulin secretion. And this is an incredibly important teaching point. When I go on medicine boards, and I still attend on internal medicine, I ask the medical house staff, define type 2 diabetes. And you know what the answer is? Insulin resistance. No, that's not the right answer. The foundation for type 2 diabetes is a foundation or a floor of insulin resistance, but the defects, a beta cell defect. And I'm pleased to learn about what Dr. Kreins is doing here and the beta cell focus of the research that's going on here that really relates to both type 1 diabetes and type 2 diabetes. We're talking about a beta cell defect. We're not talking about insulin resistance alone. Now, here's the recent map by Leaf Group and his group, and I'm not going to go through all these pathways, but the genes continue to increase. And then just this week, this paper came out, high-resolution genetic maps that identify multiple type 2 loci at regulatory hotspots in African Americans and Europeans. So this is really stated conclusively as sequencing 3 cosmopolitan locations providing candidate functional variants that precisely co-locate with cell-specific chromatin domains and pancreatic islet enhancers. These variants have large effect size and are common across populations. And most of the genetic data I threw up on the slides for you just to peruse quickly is from Caucasian populations. And now this paper really relates now to African American populations in addition. So what do we make of all this genetic data? Well, not much. Because if you look at rare monogenic variants that relate to obesity and or type 2 diabetes, we're talking about less than 1% of the population we see in the clinic. The MODY is a genetic syndrome that often occurs in the young, less severe glucose intolerance, easily treated by sulfonylureas. That's 1 to 5%. But look, only 5% of obesity or 15% of type 2 diabetes relate to these common gene variants. So what's this family history all about? Well, maybe this is entirely epigenetic, but there are other possibilities. Additional variants with smaller effects, less frequent variants with larger effects, untranscribed DNA, long terminal non-repeat sequences now that have been identified, microRNAs, gene-gene interaction, gene-environment interaction, and finally, the epigenetic era is upon us, and likely this is where a lot of the genetics of type 2 diabetes and obesity arises from. Now, what I'm going to do going forward a little bit is recognize now the pathogenic factors that relate obesity to type 2 diabetes. So we have the diet, obesity development, and the genetic predisposition. And the genetic predisposition also, as I pointed out, relates to insulin resistance and the beta cell defect. And the end product of all this interaction is type 2 diabetes. So let's look at insulin resistance first of all. Now, this is a slide that I published in the Lancet Review on the Metabolic Syndrome in 2005. And I think just a take-home message from what is the metabolic syndrome, it's the elephant in the room. And metabolic syndrome is really insulin resistance. So that's what this is. And by the way, there are plenty of obese people that are insulin resistant that don't have type 2 diabetes. And back to the beta cell defect. All right, so I think if you think about the most sensitive parameter of insulin sensitivity, it's anti-lipolysis. So I'm in the view that ultimately this whole insulin resistance paradigm begins in the adipose tissue. And there's a release of free fatty acids, which are also regulated by the paracrine effects of tumor necrosis factor, IL-6, and other pro-inflammatory cytokines. These then drive the liver to ultimately accumulate fat, because all the fatty acids going to the liver can't all be secreted, but some of them are. And so the VLDL increase on the top relates to the overproduction of triglycerides coming from all the lipolysis products that reach the liver. This also drives the production of pro-inflammatory biomarkers such as CRP. And the lipoprotein disturbances that are part of the metabolic syndrome, including reductions in HDL, high triglycerides, and the presence of a form of LDL that was thought to be causative for heart disease. I don't believe it for a moment. Small dense LDL is not worth measuring clinically and has no relevance when you consider confounding variables in cardiovascular disease. But now, with all the insulin resistance, the liver makes more glucose, which drives more insulin secretion here. And here we have a major defect in insulin action in skeletal muscle that relates to the defect in insulin-mediated glucose transport into the muscle, with reductions of glycogen and a preferential inhibition by fatty acids that relates to the systemic effect of the increased lipolysis. And then we have the prothrombotic state, which relates to the production of fibrinogen by the liver, and in pi1 by adipose tissue that relates to the tendency to more thrombosis. And then finally, we've got the hypertension component up here on the top that relates to fatty acids again. Insulin itself probably is causative, and activation of the sympathetic nervous system. So this is a complex slide that really, I think, relates to the systemic burden of insulin insensitivity that begins with excess free fatty acids that drive a lot of these pathways going forward. Now, when we think of the pathogenesis of insulin resistance, there are multiple possibilities about pathophysiologic mechanisms. Caloric load versus energy expenditure. Clearly, if you overfeed people, and we've done this in a setting of sleep restriction, working with Ken Wright on the GCRC, ultimately that drives the production of weight gain and also insulin resistance. Metabolic effects, I've talked about free fatty acid burdens, ultimately resulting in defects in multiple organ systems. Ectopic lipids, shown on the last slide for the liver, but actually in people that are insulin resistant, they put extra fat in their skeletal muscle, they put extra fat in their cardiac muscle, and they actually put extra fat in the beta cell, which has been apparently capable of modifying glucose-stimulated insulin secretion. And then the whole issue of pro-inflammatory cytokines, ER stress, and other distal mechanisms that relate to cellular metabolism. All of these have been defined in part as part of the insulin resistance syndrome. Now, in terms of fat, some fat's good for you. The subcutaneous depot is really an energy storage depot that doesn't relate to systemic insulin resistance. But when you put the fat in the intra-abdominal compartment, then ultimately we're looking now at the visceral accumulation with all the metabolic syndrome contributions. And waist-hip ratio, which for most populations relates to an increase in intra-abdominal fat, is the predictor of negative outcomes, not subcutaneous adipose tissue. Now, of course, people want to lose fat, and they could care less what their visceral fat is. And I didn't put the slide in, but I might just mention a kind of a fun study we did. We did a liposuction study, which was an R01 grant in normal weight women who didn't like their saddlebags. So the question was, is fat defended if we surgically remove fat from the subcutaneous depot? So we took our surgeon, ultimately Chris Law, took 7 pounds of fat out. The outcome was to be assessed 3 years later. And what we showed that within 1 year, all the fat came back. So these women, this was a randomized trial. Some people got liposuction. Some people got delayed liposuction for a reduced cost. All the fat came back in 1 year. You know where it went? It went from their hips and below their umbilicus to the visceral depot and their waist. So they were happy with the result. But it just shows again that adipose tissue is regulated. And if it's a visceral depot where the excess fat is stored, we have kind of bad news to follow ultimately downstream. So the idea is omental versus subcutaneous fat is associated with the production of all kinds of factors that relate to the insulin resistance paradigm, whereas lean fat, if you will, subcutaneous fat, is associated with more adiponectin, which is a good guy, more omentin, and an anti-hyperglycemic effect. So it's not only excess fat, but it's the distribution of fat that really relates to the phenotype of insulin resistance and ultimately type 2 diabetes to follow. So multiple papers in the early 2000 years showed the presence of actually macrophages within adipose tissue, which is shown here in an obese patient versus a lean patient. And these macrophages tend to be pro-inflammatory in terms of the products that are produced and ultimately give rise to some of the insulin resistance we see. Now, this is a paper that I worked with Charles Dinarello at the University of Colorado ultimately that was a very kind of interesting study because what it showed is that we knocked out the interleukin-18 gene, which is a pro-inflammatory cytokine. We got a metabolic phenotype. And I think it just raises the question, so there possibly is a role, a physiological role of pro-inflammatory cytokines. This is simply the removal of one gene product that's pro-inflammatory. These animals overate, they got hypertriglyceridemia, glucose intolerance, and ultimately had a metabolic syndrome kind of phenotype. Now, mice are not humans, but I think this reflects, the science of regulation of energy balance needs maybe an ongoing look of the role of pro-inflammatory cytokines in terms of how we control food intake and energy expenditure. Now, this is a very important slide because this is the disposition index described by Richard Bergman, then at UCSC, now at Cedars-Sinai. So what we're looking at here is this relationship between insulin resistance on the x-axis and insulin secretion on the y-axis. And so here's this curvilinear relationship between insulin action and insulin secretion. So if you have defects in insulin action, i.e. insulin resistance, if the beta cell responds well, you maintain normal glucose tolerance. And if you, in fact, have a lot of insulin sensitivity, let's say you're an athlete and you really burn a lot of glucose and you're very insulin sensitive, you don't need much insulin secretion to maintain normal glucose tolerance. But let's see what happens when, in fact, impaired glucose tolerance in type 2 diabetes occurs. And work by Lee Perot and Brian Bergman and my own group, in addition to many others, have shown in impaired glucose tolerance, you already have a defect in insulin secretion. So these people don't have diabetes yet, but they fall into this gray zone of impaired glucose tolerance. But then, ultimately, when type 2 diabetes develops, that insulin secretory defect really fails in a dramatic way. And if you think of all the genes I showed you relate to type 2 diabetes, most of them related to insulin secretory gene products more so than insulin resistance. So here's the idea in terms of the onset of type 2 diabetes. You have normal fasting glucose. Then as time goes on with the insulin resistance paradigm, you in fact get hyperinsulinemic. Then ultimately, as glucose intolerance worsens, you get postprandial hyperglycemia. Here's when the diagnosis is made. But notice now that the insulin secretory defect is starting to show up. So here's insulin resistance, hyperinsulinemia, postprandial glucose, and finally the diagnosis is made. And of course, the beta cell continues to fail. Now, we've all seen patients in the clinic who are on metformin for 20 years. So that slope of decline of beta cell function is very individualistic, and we really don't understand that very well. But I've seen people within 3 months who go from metformin to a TZD and now with a GLP-1 receptor agonist, and now they're on insulin 3 to 6 months later, and that slope of decline is really rapid. Now, what the scientific explanation is for those differences from patient to patient, I don't know, but pay attention to those differences between patients in terms of how the beta cell is ultimately altered and more diseased as time goes forward. Now, if we look at beta cell volume, there's really a problem here in the technology for beta cell volume assessment by magnetic resonance imaging or PET-CT is really quite difficult, and that technology is still being evolved. But beta cell volume has been shown to be, by Andy Butler's group, reduced in patients with obesity and type 2. But notice in normal patients with obesity, beta cell volume is higher. Now, don't conclude that beta cell volume equals beta cell function, because there are people who have reduced volume of the beta cell mass who have normal insulin secretory capabilities. But this is an ongoing area of research, and unfortunately the technology yet is not sufficiently sophisticated or sensitive to make this real time in terms of assessing how beta cell volume relates to function. So let's think of beta cell decompensation. These are all the factors that probably give rise to a greater likelihood of developing type 2 diabetes. And you see them listed there. I'm not going to go through them again. We've touched on most of these in the previous slides I've presented. All right, now the beta cell defect. I'm not talking to people in the audience who know a lot about this, so I'm not going to spend a lot of time here. But the beta cell defects, many of these are the same factors that relate to defects in insulin sensitivity. I'm talking about mitochondrial function here being a major area, glucose uptake and metabolism downstream, issues that relate to calcium flux and membrane depolarization. All of these factors in the beta cell may be actually reproduced in insulin-sensitive tissues. So therefore, is it simply the same biochemical and molecular alterations in the beta cell and in the skeletal muscle and other insulin-sensitive tissues that give rise to this? I don't think so, because there are many people that are insulin resistant have some of these mechanisms defined in the liver or in muscle, and their beta cells continue to work. So I think that's an overly simplistic view, but keep in mind we're in a gray zone in terms of understanding the downstream molecular defects that relate to both insulin resistance and insulin secretion. The mitochondria we've mentioned the role of adipocytes or adipokines, and now gut factors, the microbiomes, getting a lot of attention. Work by Jeff Gordon at WashU and beyond really has identified that the types of microbial flora that we have in the gut relate to products, perhaps short-chain fatty acids that can modify both insulin sensitivity and insulin secretion. And cytokines and inflammation. And by the way, the point of that slide I want to make is also there's evidence in studies in rodents now that this same type of impact of cytokines and inflammation may exist in the hypothalamus and may actually relate to defects in the regulation of orexigenic peptides that ultimately can be etiologic in the cause of excess body weight gain and maybe even in type 2 diabetes. And in fact, in work I'm not talking about today that I mentioned briefly in the endocrine seminar yesterday is that we've identified neurons in the liver that feed back into the PV end of the hypothalamus that are altered by lipid processing in the brain. So we know that there's a communication between the liver and the brain in terms of glucose tolerance, and that's work we're doing with Andrea Zombach at Tulane. But we now know that fat sensing in the brain relates to the activation of those same types of neuronal pathways. So there's a lot to be learned about the hypothalamus and its role both in maintenance of body weight and in glucose and fat metabolism. Now, Steve Kahn and I from the University of Washington constructed this slide a few years ago that kind of related to what we call the natural history of obesity. So basically, we're looking at age-related weight change. You notice that slopes up, and it might be better represented as age-related changes in body composition. So even though weight tends to stabilize when you get into your 50s and 60s, ultimately lean mass tends to diminish and fat mass tends to increase. Now, if that fat mass is mostly subcutaneous adipose tissue, you're probably okay because that's a sink where fat's doing what it's supposed to do. But often that fat reaccumulation, particularly in women postmenopausally, tends to be more visceral. And so we think that some of this age-related weight change may be related indirectly or directly to cardiovascular disease risk. So this primary weight gain to excessive weight occurs over a time period. Then this weight loss can be achieved by multiple mechanisms, and I'll come back to that momentarily. But then this weight regain phenomenon is just like that liposuction study I told you. Remember, normal weight women who had 7 pounds of fat removed, it's all back in 1 year. This is the biology of weight regulation. It's not simple. It's complex. But we all know that the best treatment for obesity is prevention. We don't do very well treating obesity, but preventing it is something as a population, as a global population, we need to be more concerned about. So this, if you will, is the therapeutic space, inducing weight loss and preventing weight regain. And that's where our attention needs to be placed. Now let's look at how ultimately insulin resistance may be modified by successful interventions that relate to weight loss. Let's take a look at a patient. We're all doctors, most of us are at least, or we're healthcare professionals. So we've got a 48-year-old woman here who seeks your attention for weight reduction, and you're the expert here, okay? You may not feel that way, and the more we learn, the more we don't know, but nevertheless, you're the physician who's being asked to have her lose some weight. And she's been on every diet in the world, with only a few that have worked for around 6 months, and then she regains. Her current weight's maximum. So that relates to kind of a weight history. I want to know what birth weight was. I want to know weight at first menstrual period for women. I want to know high school graduation weights. I want to know weight for women before and after pregnancies. And those are kind of the questions that really relate to this concept of weight regulation. So high school weight's a good one because it's a weight most people remember, the weight they were when they got married. So anyway, these are good time periods to assess obesity development. So she's currently at her maximum body weight. So presumably she's regulating her weight at that level. Past medical history, she's hypertensive. She's on a combination thiazide and ARB. Her fasting glucose is 116, which is not normal, but not type 2 diabetes. Family history is positive for both heart disease and type 2. And her blood pressure is 134/86. Her waist circumference is excessive at 35. Her weight's 205. Her BMI is 34.1. And she's obese. Total cholesterol 137, triglycerides 250, or HDL's low at 32, or LDL's normal. Often obese patients have normal LDL cholesterols, right? So don't expect them to be part of the metabolic syndrome complex. For non-HDL cholesterol, which some people like more, is 105. Fasting glucose on repeat is 111. Her A1C 6.3%. And in that gray zone of pre-diabetes from 5.7 to 6.5, the closer you are to 6.5, the greater likelihood she has of developing type 2 diabetes. Her C-reactive protein is kind of borderline, 1.6 milligrams per liter. Now, if you want guidelines for the approach to the obese patient, you've got a joint venture between the American Heart Association and the Obesity Society that Mike Jensen and Donna Ryan co-chaired, and this is an extensive list of how you go about treating obesity. Let me summarize this report. Whatever works, do it. And so the idea of low fat versus low carb, behavioral modifications, all these things, if the patient gives you a history that on Weight Watchers she did best, go back to Weight Watchers. The most important predictor of a success of weight loss is compliance to the program. Doesn't make any difference what the program is. You got to follow the program and abide by it. So back to this diagram where we're thinking now of preventing type 2 diabetes in people that are obese. I'm just going to show you a couple of studies. This is done by Ellie Farinini's group in Pisa. Ultimately, here's the obese glucose tolerance test. Here's the glucose in obese patients who are insulin resistant. Here's in lean patients as control. And here's the glucose tolerance test after 12% weight reduction and maintenance. Here's the hyperinsulinemic response in obesity. Here's the reduced obese state. Notice it's not normal. It's still elevated, but it's better. And here's the lean patient. So the idea here is that weight reduction, ultimately insulin sensitivity improves if we simply use the oral glucose tolerance test. And I'm not going to show you a lot of euglycemic clamp data, which would bore you to tears. But anyway, the insulin sensitivity both in the liver and in skeletal muscle improves after weight reduction. So now the diabetes prevention program. This is a study that most of you recall or should know anyway. We're looking at a large percentage of men and women who, in fact, need weight reduction with a BMI average of 34. Actually, there was a fourth arm where thiazolidine was used, but because a patient died of liver failure on that TZD, that was eliminated from the endpoint. The study was halted prematurely at 3 years, and here's the data that ultimately the benefit of lifestyle outweighed the benefit of metformin, but metformin was still successful. So we're talking about mechanisms to modify body weight to reduce the likelihood of developing type 2 diabetes. So metformin, intermediate effect, lifestyle, quite good at a 60% reduction. And this study has been repeated in Finland and in China in multiple cohorts around the world. So we know if we can get compliant people who can lose weight and keep it off, ultimately we can reduce type 2 diabetes. But notice that over time, it's not totally prevented. And if you go back and look at this database, ultimately it's probably people that have greater defects in insulin secretion from the very inception that progress more likely than those who did not. And ultimately, Dick Hammond subsequently showed that it's the amount of weight reduction. It didn't make much difference whether it was metformin, whether it was the physical activity paradigm, or whether it was the focus on a low-fat diet. And by the way, I'm not here to claim that a low-fat diet is what causes weight loss. You can lose it on a low-carb diet, so it doesn't make any difference what diet you use. But from the DPPP, it's the amount of weight reduction, no matter how you got there, that predicted the benefit of the intervention. Now let's think about the treatment gap. We kind of implemented a program in the clinic for this woman, and she's frustrated and she didn't lose much weight. And by the way, when I really want to talk to a patient about obesity and its management, I need an hour. This isn't a 10-minute conversation, because I want to get in a good obesity history, I want to assess comorbidities, and I want to make sure that he or she's we're picking the right program. And we have a very sophisticated program at the Anschutz Health and Wellness Center in Denver that is very effective at group therapy, individualized personal trainers, and all that kind of stuff. But I think beyond that, what do we do that might be helpful in the way of pharmacotherapy? And I think drugs are an issue, and I'm going to show you kind of where this whole field's at very quickly. So I'm summarizing all the currently available compounds out there. Phentermine, orlistat, Qsymia or phentermine, extended-release phentermine, topiramate, lorcaserin, now Trexon, bupropion, and now liraglutide. By the way, the 3 milligram injection of liraglutide is $1,000 a month. So not too many people have $1,000 to pan out, and most insurance plans are not going to pay for this. So what I'm looking at here is the long-term recommendations is not there for phentermine. Here's the efficacy beyond placebo. That's beyond placebo. So the maximum effective therapy is probably phentermine topiramate, but I can't get people to take that who don't have side effects. Anyway, but here's the side effects, and here, orlistat, of course, is, we laughed at that at dinner last night, but anyway, the orlistat effects are not there and pleasant for most people. But look at the cost of these things. $1,000 a month for a weight loss drug? But look at phentermine. Now, I'm going to tell you kind of a crazy story very quickly about phentermine. Fen-phen, you know, was a combination that was quite effective, and we used that in the late 80s, early 90s, and Michael Weintraub's data was supportive of phentermine topiramate or phentermine dexfenfluramine combination. But then the downside of pulmonary hypertension and cardiac valvular disease came up, and dexfenfluramine and fenfluramine were removed from the market in 1997. So I started thinking, gee, if I want to give a weight loss compound, what do I do? I don't have much out there, and orlistat wasn't something I was fond of. So I started paying attention to phentermine and who responded and who didn't. And I started gathering enough data to pilot a study that ultimately we confirmed by a more objective approach to the question. So here's work that Liz Thomas with me and Mark Cornier did that published last year in Obesity. The greater hunger and less restraint predict weight loss success with phentermine. And what I'd found is this, that phentermine works well when people are hungry, but not at all when they're not. So this is one question in the clinic. Do you eat because you're hungry? 40% of obese patients I see have hunger-motivated food intake. 40% have no hunger-motivated food intake. They're anxiety, stress eaters, depressed, or whatever else. And 20%, I'm not quite sure. But I give a 30-milligram dose of phentermine at 10 a.m. in the morning, and in 6 weeks, if you're not down 5 pounds, stop the drug. Because if people respond, they respond. And I have people on phentermine who have lost 20% of their weight now for 20 years. So I'm not pushing this, and phentermine's not made by a company, so there's no conflict here. But this is the cheapest effective therapy you can go with in the right patient in the clinic. Think about this a little bit. Side effects very quickly. If you take it too early, you have too much food intake later in the evening. If you take it too late, you may have insomnia. Now, people with cardiac arrhythmias and things like that or uncontrolled hypertension, you want to be careful there, Rick. So I think I'm thinking about your cardiologic community that you don't want to be giving the drug to the wrong people. But I've got many, many people who've responded quite well on this, and I think that's something you ought to think about more often in the clinic. Now then there's surgery, all kinds of procedures out there now, gastric bypass, sleeve, biliopancreatic diversion, and to prevent type 2 diabetes, the SOS study in Sweden has shown very nicely, if you get surgery, the likelihood of developing diabetes versus not getting surgery is quite demonstrable over time. Here we're looking at a 15-year outcome, medical management, surgical management. And ultimately, glucose and insulin prevented by surgery, the hyperglycemia and the hyperinsulinemia developing in the medical group was prevented by either a sleeve or a gastric bypass operation. So surgery is finding its place. And ultimately, this is data carried out by Tom Inge, who's now recruited to Cincinnati. He's kind of the icon of adolescent surgery. You know, these kids that have BMIs of 45 and 50, they're not doing well on any other therapy. So I think thinking seriously about the importance of modifying weight by a surgical approach is there. And here's the improvement going from a BMI of 61 to 38.9 in a multi-center study that Tom has overseen. Here's the glucose response, and here's the insulin response, markedly improved by substantial weight reduction from bariatric surgery. By the way, done by the right surgeon. Now, let's turn to type 2 diabetes in the next few minutes. So weight loss, type 2. The big question in the look-ahead study was if you lose weight, you reduce cardiovascular disease outcomes. And it was one of those ambivalent results. So this was to assess the long-term, now 11-and-a-half-year study of an intensive weight loss program over 4 years, meaning the intervention was 4 years, but the outcome was delayed for 11 to 12 years, in overweight and obese subjects with type 2 diabetes. So 5,000 men and women, weight loss versus support and education was the randomization, age range, BMI had to be above 25. The primary outcome was the time to a major cardiovascular disease event, many secondary outcomes, and the study was stopped early because of no benefit. Now, stopped early. They extended the funding till 13 years, but they finally stopped at 11 and a half, and that's because the outcome was negative. Look at the weight loss. Does that curve look familiar? Look at the control group. Actually, they're losing some weight. So just being randomized into a clinical trial often is associated with weight reduction. But here's the patients with type 2 diabetes that had the intensive therapy. Look at the weight at 1 year going from 100 kilos down to 92, multiplied by 2.2. So this is fairly decent weight loss. But then also look at the recidivism. And here the slopes of decline of weight over the long-term intervention are equal between the two groups. Glycated hemoglobin. The initial benefit's quite obvious, but the lasting benefit is somewhat questionable in terms of the impact of weight reduction on hemoglobin A1C. Now, if you're a cardiologist, and my clinic is in cardiology, although I'm an endocrine guy, so the cardiologist, I'm speaking for the cardiology community that's into clinical trials and diabetes, and there's lots of those going on right now, and still many to come. The cardiologist's view, and I'm going to generalize a little bit, is glucose is not so important. And in the talk I gave yesterday, I tried to point out for type 1 diabetes, I think glucose is quite important. But for the type 2 studies, the glucose-lowering effect of a more insulin-intensive therapy is kind of borderline. It's there, but it's pretty soft. But we have other mechanisms that are evolving. But here, weight reduction doesn't even affect A1C very much long-term. It's a transient effect. And I would happen to ask the question, and this may be published, I just don't know, how is this related to the insulin secretory capability in people after weight reduction? I think if you're losing weight and your beta cell is already defective to the extent that it can't recover, that there's probably no benefit. But that's science that really, I think, is ultimately open to question and should be looked at more carefully. But here's the outcome. Look at cardiovascular disease events. Not a hint of benefit. So losing this much weight, at least for 4 years during the intervention with some waning over time, did not reduce cardiovascular disease events to follow. And I had a slide that I think I took out, which I'll just mention briefly. If you look at many other outcomes, obstructive sleep apnea, quality of life, degenerative joint disease-related symptomatology, these people are better. So there's no question that losing weight is good for you. HDL cholesterols were higher and remained higher. Interestingly enough, triglycerides weren't, and LDL cholesterol is actually higher in the people that got the intervention than people who had standard of care. And the LDLs went up, I think, because of a large statin drop-in the control group. But anyway, all this aside, weight loss is good for you. Don't misinterpret the data. But in terms of cardiovascular disease events, no benefit, at least in this very highly well-controlled randomized trial. Now, here are your choices of medications. Boy, they go on and on and on. Currently, including the multiple insulins out there, there are over 20 options you have to treat type 2 diabetes. But if you just put all the insulins in one group, there are 13 additional options. So let's go over this very, very quickly. So metformin's a drug of choice. Most organizations globally think that everybody with type 2 should be on metformin. I would think there are exceptions for lean type 2s whose antibodies are negative. They don't have type 1 diabetes, although we know that half of type 1 diabetes is now occurring after the age of 30. That's kind of interesting. So, but metformin, drug of choice. And Greg Schwartz, who Rick you may know is a clinical trials cardiologist at our VA, and Greg is now doing a study of metformin looking at cardiovascular disease events and other outcomes in patients without diabetes. The coattails of metformin in cancer and aging and other areas is out there, and now those questions are starting to be asked in a non-diabetic population. So metformin is relatively effective, A1C lowering, moderate, and that's the drug of choice. But now look at these other agents. I actually think that sulfonylureas should be discarded. The only benefit of sulfonylureas, other than MODI, where they work quite well, is their cost. And in a cost retainment kind of environment, sulfonylureas are still there. And when people refer to me in the cardiac clinic who have diabetes and are on sulfonylureas, I kind of pause, is this drug really necessary? I mean, the hypoglycemia, the weight gain is all related to sulfas, but I think there may be cardiac adverse effects. And if you go back over many years of clinical trials, I think sulfonylureas are questionable in terms of risk, much less benefit. And the other thing about sulfonylureas that I think need to be considered is that when randomized controlled trials where sulfonylureas are compared to thiazolidinediones, ultimately, where are they? Down here. Ultimately, it seems that sulfonylureas may wear the beta cell out. So modifying insulin resistance with a TZD tends to rest the beta cell, where sulfonylureas work by stimulating insulin secretion. And if the beta cell's already not working well, in fact, that may be a negative effect of using these agents. The thing is, they're cheap and easily used, and the meglitinides are really very similar to sulfonylureas. GLP-1 receptor agonists, where are they indicated? I think when weight loss is a goal, we know that giving liraglutide or other GLP-1 receptor agonists can be associated with some weight loss. So that's kind of nice. The DPP-4s are kind of in that same incretin pathway, and their effect on A1C is modest, but the benefit of DPP-4s is they're extremely well tolerated. And there's really no adverse effects of giving a DPP-4, and the glucose lowering is modest, but it's there. The SGLT2 inhibitors are a hot area. The EMPA-REG study showed that giving SGLT2 inhibitors, empagliflozin, reduced cardiac events and mostly hospitalization for heart failure. And the benefit did not appear to be the glucose-lowering effect. So there's another big SGLT2 inhibitor trial called CANVAS. It's being reported next month at the American Diabetes Association meeting. So watch your papers on that one. So canagliflozin is one of 3 SGLT2 inhibitors that modify glucose excretion as a mechanism for glucose lowering. The TZDs I've commented on, they're starting to resurface. The rosiglitazone story that Steve Nissen brought to our attention a decade ago has kind of waned. And although if we're going to give a TZD, we give PIO for 2 reasons. Pioglitazone is generic now. And also if we use a lower dose, the bone disease and ultimately the weight gain and edema are less likely to occur. And the studies of Actos and other ones now have been re-examined, and ultimately the IRIS study has been re-examined. Now TZDs appear to have a benefit for cardiovascular disease outcomes. So keep your mind open about TZDs and use lower doses than the past. Bromocriptine, goodness, I've never written a prescription for bromocriptine to treat diabetes. And Welchol or colesevelam, which is an LDL drug, that's approved for diabetes. I should add that down here to bromocriptine in terms of a drug that we rarely prescribe and has relatively modest effects. So here are your choices, and I think the ADA is considering now, what's the second drug of choice? Past metformin, what do you give next? And I think if weight loss is really something you want to do, either an SGLT2 inhibitor or a GLP-1 receptor agonist is what you want to do. If you're concerned about safety or adverse effects, by the way, a lot of nausea in GLP-1 receptor agonists after you start them. So you have to kind of coach your patient through that first 2 to 6 weeks on these. But once you get past there, the nausea and rarely vomiting seems to improve. So your choice really, weight reduction here, avoiding weight reduction, TZDs are something you should think about. Insulin sensitivity, resting the beta cell, TZDs, and I think sulfonylureas should be seriously considered as to whether they're necessary, or if the patient can't afford anything else, you don't have many other choices. Now, what about surgery and the treatment of type 2 diabetes? And this is an evolving space. These are studies by Francesco Rabin out of Rome and New York when he was there before he went to London. And now we're looking at the benefit of surgery versus medical treatment. So the study by the Rome group, 60 obese patients with type 2, age range shown, BMIs above 35, A1Cs greater than 7, 5 years duration of type 2 diabetes, medical treatment versus Roux-en-Y gastric bypass versus biliopancreatic diversion, an 88% 5-year retention, medical treatment versus surgery, 2 different types, with a primary endpoint of an A1C of less than 6.5 and a fasting plasma glucose less than 100 milligrams per deciliter. There's the weight reduction. So biliopancreatic diversion is a really more complicated procedure. It's not done by your standard Yellow Pages surgeon. So anyway, here's the weight reduction. Here's the Roux-en-Y bypass in terms of remission from diabetes using the primary endpoint they described. Biliopancreatic's better because it's more gut diversion in addition to modifying the stomach volume. And this effect is really incredibly demonstrable. And now, ultimately, the metabolic outcome assessed by all the variables that relate to insulin resistance, clearly showing the benefit of Roux-en-Y biliopancreatic diversion versus medical treatment. Now, are we in a position in America to pay for bypass surgery for people who meet these qualifications? I don't know. But I was privileged to be part of the guidelines that relate to the implementation of bariatric surgery to treat type 2 diabetes, which is published extensively in Diabetes Care last June. So if you're interested in that document, take a look at that. But I think we're evolving into an area where this may prove to be cost-effective lifelong to get people operated on early enough so the beta cell still works and glucose tolerance can be preserved and people can go into, quote, remission for type 2 diabetes with surgery. And now this work has really effectively been repeated by Phil Schauer at the Cleveland Clinic, and the data look very similar, and I'll not bore you with the details, but this was just recently published last month or a couple months ago in the New England Journal. So let's sum up here today what we've gone over. We've done broad strokes, and here's what I'm going to conclude about where this whole area of metabolic medicine is all about. Obesity is a complex biology with multiple contributors that is currently epidemic with some hint of plateau in Western societies and needs to be prevented. Again, if there's one take-home message, even for your own families, but in your medical counseling, think about ways you can modify behavior up front to prevent this from ever occurring. And I think pediatricians and family docs are really tuned into this now. But can this be done? I don't know. But this is where the emphasis needs to be placed. Insulin resistance in obesity is multifactorial. So insulin resistance is kind of what we think is the foundation of the beta cell defect to follow. But prediabetes and type 2 diabetes are more than insulin resistance, but a progressive defect in beta cell function. And the molecular mechanisms for that alteration really are needing much work. And I'm glad you have a group here that's very active in beta cell biology and pathophysiology. And weight reduction by whatever means can modify insulin resistance, and sometimes, and most often, if early on, can improve beta cell function. So whether it's surgery or ultimately it's simply a 5% weight reduction that's maintained over time, this is something we need to work harder on and find the best way to do it. And here's the recommendation. We need to balance our focus and funding targeted to the genetics and genomics and how they affect functional biology. So the genetics to functional biology to intervention, ultimately related to an expanded investigation of the multicentric actions of single regulators or pathways. So I think we need to drill down and identify the various players and their relative contribution to this obesity to type 2 diabetes transition. And ultimately, we need to improve strategies for bringing the science of the pathophysiology to disease intervention. So it's been really a pleasure to return to Madison. It's been a long time since I've been here. This auditorium, again, is the same and brings back many memories. And I feel privileged, Rick, for your inviting me, the chief residence. It was a great time last night. And I'm off to Philadelphia from here, and unfortunately don't have too much more time to spend here, but it's been great to return. Thank you so much.
Thank you so much. I'll ask you to call on the audience, please, and if you wouldn't mind just repeating the questions.
I'll do my best.
Over here on the right.
Yes. Thank you.
You didn't say anything at all about fasting. There are people at the NIH who've been studying fasting fairly intensively, looking at the metabolic impact beyond weight loss, looking at potential physiological benefits. Say even 2 days a week, and it's gotten into the lay media, et cetera. But is there something there? Might that be a benefit in terms of altering the trajectory towards type 2 diabetes?
The question relates to fasting and its metabolic benefits and presumably its impact on weight reduction and glucose tolerance. I've been around a guy at my institution for years who's been promoting that kind of approach to weight loss and diabetes and metabolic control, and he claims it in his patients' work. But I'll turn you to a JAMA paper about 3 weeks ago that looked at the comparison of every other day fasting versus a caloric restriction and showed no difference in any outcome they measured. So, again, it's one of those things that I think if it's working, do it, and that's measured by the biomarkers we use to assess glycemic control, lipids, and insulin sensitivity. But yet, the controlled trials have been somewhat disappointing. But I think it has merit. And the idea of fasting is what happens when you fast? Well, you release a lot of fatty acids from adipose tissue because they sustain glucose homeostasis. And, if there's one bottom line of metabolism, it's glucose delivery to the brain. So everything that happens metabolically for all of us under all circumstances is maintain glucose delivery to the brain. So when we fast, fatty acids go up, they get converted to beta keto acids that ultimately are fuels for the brain to replace glucose. So anyway, but unfortunately the applications of fasting to the treatment of type 2 diabetes or obesity has been mixed, and I think the most recent trial shows no additional benefit.
to the right here.
To the right, yes.
Hi, I'm a medical internist. I have two questions. The first one is, we're deciding UW Health, what are we going to do to make the most impact on a population of patients? We're looking at pediatrics, and we're thinking, are we going to target no kids ever smoking, kids not becoming obese, or having mental health providers in place to help with significant mental health needs? So, I'm wondering, from your perspective, what would you choose?
So the question is an impossible one to answer. So the choices are smoking, no smoking, controlling body weight during growth and development, and the third was more
Supporting mental health for adolescents.
mental health for adolescents. Gee, which one of those would you choose? I mean, it depends on kind of what you're going to be measuring as the long-term outcome. Clearly, smoking needs to be at the top of everybody's list. Nobody should smoke under any circumstances at any time in their life. And because it's an addictive behavior, teenagers who start to smoke are a place that we need to put our foot on the brake and do everything we can to cease that behavior. Now, I'm trying to point out to you in terms of weight gain to prevention of obesity is the best therapeutic for obesity-related disease going forward. And I didn't comment on this today, but obesity relates to all kinds of outcomes that I didn't really touch on today. Cancer risk in obesity. There's a recent review article. You wouldn't believe the number of cancers. By the way, kind of a trivia question. What's the most common cancer in obese patients in men and women in terms of comparing the obese patients to controls? You know what it is? It's adenocarcinoma of the esophagus. Is that all reflux-related disease and Barrett's? I don't know. But so that, I think, prevention of undue weight gain during adolescence, and by the way, during college years, it's the second time where there's a lot of excess weight gain. Now, some kids go to college and they become increasingly active. But boy, there's a lot of sedentary behavior in college students. But the third area, mental health in adolescence, I can't touch that one. I just can't answer that one adequately.
I think we're going to work on obesity with kids and adolescents as well. So great, thanks.
Any further questions? Good. Well, thanks again.
Well,
it's been my
you.
pleasure.